For decades, American products liability law has treated physicians as learned intermediaries between manufacturers and patients. The doctrine is most familiar in prescription drug cases, in medical device cases. A manufacturer satisfies its duty to warn by informing the prescribing physician, not the patient directly. The law assumes the physician's training and clinical judgment make her the best interpreter of risk. That framework fits comfortably when the product is a drug or a device. The manufacturer provides information, the physician interprets it, but artificial intelligence complicates that model. When an AI system recommends a diagnosis, flags an abnormal image, or predicts clinical deterioration, it's not sitting passively like a drug label. It's participating, at least functionally, in the clinical reasoning process. Courts will almost certainly begin by treating AI as another clinical tool, applying the same reasonably prudent practitioner standard they have always used. That means physicians may face liability for over-reliance, following an AI recommendation that conflicted with the patient's presentation without being able to explain why it made sense. The AI told me to do it defense is unlikely to succeed. But the harder problem runs in the opposite direction. As AI systems become more accurate and more deeply embedded in clinical workflows, physicians may also face liability for under-reliance. If a validated tool flags a malignancy and the physician dismisses it without justification, courts will ask why. That pattern is already emerging in cases involving automated ECG interpretations and CT alert flags. Once a tool is widely validated, ignoring its output requires explanation. This is where the learned intermediary doctrine may begin to bend. The doctrine assumes the physician is the superior interpreter of medical risk. But in well-validated domains, radiology, image classification, sepsis prediction, diabetic retinopathy screening, AI is already matching or exceeding the average clinical accuracy. The physician may remain the legal intermediary, but no longer the sole epistemic authority. Courts may increasingly ask not just whether the physician exercised judgment, but whether that judgment reasonably accounted for what the AI said. For practicing physicians, the immediate implication is documentation. The chart of the future may need to record not just the final diagnosis or treatment plan, but what the AI suggested, whether the physician agreed, and why. Not because the AI is binding, it isn't, but because ignoring it silently is becoming harder to defend. The law will not announce a new rule for AI malpractice. It will adapt incrementally, extending familiar doctrines to new facts. The physician will remain the learned intermediary. The question is whether, in the age of clinical AI, the physician is mediating between patient and manufacturer or between patient and machine judgment.